Hello, everybody, and welcome to the Precision Medicine virtual event. My name is Florence Comite, and I will be speaking on precision medicine and health in action, practicing an N-of-1 approach in the clinic. Please feel free to submit questions during my presentation. I'll be happy to follow up with you via email. My learning objectives for this presentation is first to understand the core principles and potential applications of precision medicine and N-of-1 healthcare. And secondly, to review a practical model for leveraging N-of-1 data to detect and predict disease. NIH, of course, put precision medicine on the map. This started in 2015 when President Obama announced the fact that precision medicine meant that each person would have the right drug at the right time for the right person. And very recently, about a year ago, on May 6th, which happened to be my mom's birthday, NIH announced that national enrollment for All of Us research program was set to advance precision medicine. I enrolled, and I encourage all of you to enroll because diversity is going to be key. The definition that NIH uses, which is slightly different than mine, is that precision medicine is an emerging approach for disease treatment and prevention that takes into account variability in genes, environment, and lifestyle for each person. And this is why precision medicine matters. Each of us is very different. You don't have to be as distinctly unique as Shaq and Danica. But we do know that even the top 10 drugs, which were widely studied and published in peer-review, evidence-based medicine models, don't work well for everybody. And here you can see in one of my favorite papers published in Nature, Personalized Medicine Time for One-Person Trials in April of 2015 by Nicholas Stork, that some of the top 10 medications are only useful in one of many folks that they're used in. So there's an issue with the fact that not all of us appropriately can use medications that have been widely tested. As an identical twin, I knew that a long time ago. And when genomics started emerging, when the billion-dollar genome was published in the 1990s, I was fascinated because as an identical twin, genomics always was of interest to me. But I knew then that I was not quite identical to my twin sister, and I was interested in all the other omics, whether it was metabolomics and looking at metabolism or hormones, or looking at the microbiome, or looking at or any aspect of the omics, it would all be pertinent. And there I was at Yale, creating women's health and men's health, and interested in collecting any and all of the data I can on each unique person, anticipating genomics, but wondering if, as a clinical investigator, I could actually determine what was going on beneath the surface in anticipation of genomics. So in collecting information, whether it was about the metabolism or hormones or looking at personal and family history and lifestyle issues, putting together all these domains and the tsunami of information allowed me to detect variations in what was expressed by the gene and in how a person lived would tell me what was going on under the surface. And in doing so, we were able to detect, predict, and actually look at reversing the health trajectory or the disease trajectory so that it wouldn't go downhill with aging. This would allow an individual to own their own health trajectory. So why is that critical? Well, it's critical because our health actually peaks before 30. And as we hit our 30s, we begin to notice changes in our health. And that happens physiologically. Hormones change, metabolism changes, heart disease begins to permeate and emerge in males before the age of 40. We begin to change in terms of the way bone turns over, fertility, and a number of markers of health, biomarkers of health, are notable below the surface. As a clinical investigator, that was apparent to me. So I began to collect that data in the hopes that we could identify those biomarkers and reverse those changes before decline set in. And the promise of sustaining health for a lifespan would be available then to individuals. So to me, this led to another definition of precision medicine that predated what NIH is now trying to do and allowed me to collect this data. So precision medicine in health is a data-based approach to optimal health and longevity that integrates and interprets an individual's N-of-1 health portfolio over time to detect, predict, and reverse disorders of aging with personalized interventions. I want to explain what that means from an N-of-1 perspective. What essentially we're saying is that when we study, we're studying a single patient as the entire clinical trial. Now, that's the way I thought more than 2 decades ago, that by collecting individualized data and collecting it in such a way that while the clinic looked like a clinic by perception, we were actually using it on the surface as a clinic, as a center, but underneath we were collecting data in a very appropriate way, but in a singular way where every patient had biomarkers collected at baseline as if it was a clinical investigative trial, not unlike what Nicholas Stork was advocating in this paper in Nature, that it's time for one-person trials, that precision medicine requires a different type of clinical trial that focuses on the individual but doesn't average responses to therapy in any way of interpreting data. And by doing so, what we collected was all this individual data that you see laid out here. I couldn't embed a video here, but you can go to the website and check this out at comitemd.com. You can see that what we're interested in all these hexagons is all the bits and bytes that make up a person's life. Their personal and family history, which I used to think of as a poor man's genetic test, and now recognize after years of collecting on thousands and thousands of individuals longitudinally that it's a very rich form of information because it's in the emergence of genetic data. So family history, personal history, lifestyle, whether sleep, nutrition, the way we live and exercise or don't, whether it's 10,000 steps or several steps a day, metabolic data, hormones, and functional tests. We look at VO2 and exercise testing and metabolic equivalence, which is a great predictor of morbidity and mortality. We also collect any and all digital data, wearables, and we look at apps. And whether it's several SNPs or the whole genome, we also collect genomic data. And by doing so, we connect and all these dots, we integrate it and we interpret it, and we find out where these spots, the weak spots are, or the liabilities, as you see in the red dots. And then we intervene and hopefully cause them to turn green so there's health that's created. And we think of that as an N-of-1 precision health engine. Another way of looking at this process is remotely we can collect records and surveys. We don't need to see an individual to do that because we're looking below the surface. And then we can do a blood draw that looks at all these biomarkers and interpret it through a telemedical consultation where we actually connect the dots for that individual to get them comfortable with what we're seeing beneath the surface emerging. And while we see them and they visit us, we also collect bone density data and body composition. We do all sorts of testing at the center in New York. And then we tailor interventions to achieve optimal health. And we continue to do that over time while assessing outcomes with various markers. These are a number of our clients, and we can see any and every one. And you can see they all look unique. We can assess what's going on beneath the surface in any way, because what's on the surface does not really tell us what's happening beneath the surface. You can look amazing, such as this gentleman in the middle, but yet what's going on underneath may not look as good. So I got a call rather recently from a 47-year young male who was actually in very good shape. He had an 8-pack, in fact, and that's what he reported. But he traveled frequently between time zones as he was an actor with a very comfortable lifestyle, worked out 5 to 7 times a week, and was eating a pretty low-carb diet, no alcohol, smoked occasionally. He did crave carbs at night, had occasional peanut butter and jelly sandwiches, and could get through a pint of ice cream. Didn't like the fact that he had these cravings and couldn't stop them. No acute symptoms at all. He did sleep well, 6 to 8 hours at night. He had a family history of cardiovascular disease and diabetes, and he felt that this could be the underlying reason for why it was disturbing him, this carb craving, because he saw that his father was now an insulin-dependent diabetic and also had some heart disease. It was hard for his father to ambulate without pain, and he was worried that he was following in his father's tracks. And other family members also had heart disease and diabetes. And he really wasn't feeling as good as he did in his 20s, even though he looked great on the outside. Now, anyone hearing this might have felt that, wow, this guy seemed great and there was really nothing to worry about. So from a conventional medicine point of view, anybody who looked at this would have thought that I lost my mind to think that there was any problem going on with this gentleman, and that I should have just told him, just take it easy, and you're a little anxious and there's nothing to worry about, and come back when you're really sick because you're doing great. But the truth of the matter is there's no way to tell if he's doing well. And the fact is he was giving off some signals based on the thousands of people that I've seen over the years that told me that underneath his carb craving, his family history, and a number of other signals meant that there was something going on under the surface, and the data would speak to it. So we went on to look at the data. And the way we look at data tells us that he had issues in his carb metabolism, because somebody like this 47-year young gentleman who was doing mostly everything right should not have an elevated fasting sugar as shown here. His fasting sugar should be between 70 and 80, and instead it was 91. And his hemoglobin A1C optimally should be closer to 5 or less, and it was 5.4. And his insulin should be undetectable when you fast for several hours overnight, and it was not. And there were a number of variables that were not what they should be. His cholesterol was too high, and those sent signals to me that said, we should start looking at what's going on here, because he's not in good health, and this is a pattern that's bound to go downhill with aging. So we did just that. We took a look at a deeper dive into his lipids. And as you can see here, without even looking at the numbers, that he had a lot of red. Red is bad. So this is a particular test that looked at lipid particles. And he had high numbers of the bad small particles, the LDL. Not only that, but he had genetic variables that said that they were almost unchangeable unless he had some radical interventions. And he had some genomic SNPs as well. But here what I'm pointing out is we didn't need to wait for the genome to be available to say that this was a gentleman who was headed, as many of us are with aging, down a path that would take away optimal health. And as he aged, he too would be heading towards diabetes and heart disease. And he had SNPs that suggested if we didn't turn around his supplements and make sure that he was getting, for example, sufficient vitamins, such as B vitamins, because he had a variant that would not allow him to take in certain B vitamins and methylate them, he was also at higher risk for heart disease. And for all those reasons, we chose to intervene to see if we could turn around his health issues. Here are some of his initial findings that I already described. He had an abnormal carbohydrate panel, which speaks to sugar and hemoglobin A1C and insulin, abnormal lipids or cholesterol. He also had a low magnesium and a vitamin D. He had an elevated homocysteine, which spoke to inadequate vitamins, in particular B vitamins. He had a high sex steroid binding globulin. He had something by pattern alone as an endocrinologist that we would describe as hypogonadotropic hypogonadism, which meant he had fairly low testosterone. And we made several recommendations that would lead to deeper testing, looking at an oral glucose tolerance test with repeat baseline testing, advanced lipid testing, and genetic testing. We also chose to recommend deeper cardiovascular assessment, doing something called a coronary risk ratio, which we had obtained, and we wanted to do a computerized tomography calcium score along with a pulmonary CT and a CTA or CT angiogram that would look to see if he already had stenosis due to the underlying risks that he was facing, as well as the family history. We suggested that he increase his consumption of protein with carbs, and we wanted to help him stop smoking altogether because that was escalating his risk of these underlying conditions. And he was fully on board with the program. This is what he looked like when he came in, and I think you can appreciate how good he looked on the surface. Again, this would be a person who everybody would agree looked fantastic. Why were we searching for any data that would tell us otherwise? But in pointing out the precision with which we want to look at data, you could see that the data in conjunction with his story gave us this valuable insight. And whereas he checked out with respect to his lean muscle mass and his percent body fat of 9.7, he still had a ways to go with health. And here's where the N-of-1 approach makes a difference, because he would have qualified as somebody that you might not want to spend too much time in. You might think it's a waste of time and money to do anything more than just a superficial annual exam. But this gentleman was headed towards poor health. We also did a VO2 max test, which would give us insight into something called metabolic equivalence, which is a very strong predictor of morbidity and mortality. And he looked very good that way. And with some intervention, even early on, we actually improved his metabolic equivalence significantly within a few months. But here's his CT angiogram and his CT calcium score. And he was already in the 75th to 90th percentile due to the amount of calcium in his coronary arteries. And he had some significant stenosis, meaning there was already plaque built up. This was not good news for a 47-year-old. And this is the reason, not in this particular gentleman, because he already wanted to intervene, but this is the reason you might see a marathoner who thinks he's doing everything right die of a heart attack, because there are changes that go on beneath the surface that lead to disease. And when you don't collect data that's precise and marry it to the story, the way we look at N-of-1, data in each individual person, and when you look to just averaging the mean and thinking somebody who looks this good must be healthy, you are going to miss disease. And as we age, all of us are going to have disorders of aging. So the N-of-1 programming, for those of us who are familiar, and many of you will be familiar with N-of-1, it's developing a data-informed intervention, whether it's using sleep or modalities that are quite conservative but can change radically the course of your health trajectories, or those of our patients, or as we like to think of them, clients, because we don't want them ill. Nutrition, exercise, or doing more advanced testing to have us dig deeper, or wearables, which is something that we also spoke to with this gentleman. Supplements or medications. We want to intervene to make sure that we have progress. And in this particular gentleman, we are interested in doing some intervention, and he was able to choose a few things that made a difference. For example, we suggested that we discontinue intermittent fasting and we tried a ketogenic diet. We reduced his strength training and we increased more intermittent aerobic and steady cardio to minimize further increases in muscle. We also suggested that he start a hormonal intervention to utilize his natural physiology, something called human chorionic gonadotropin. We started him on a D vitamin. We also started him on some omegas and cocoa flavanols to increase memory, which was also an issue. We gave him root of astragalus because that would help lengthen telomeres, is excellent data. And we gave him a prescription medication to help abate his desire to smoke. So there were a number of interventions that helped move him in the right direction fairly rapidly, and he was on board with almost all of it. We also, because he was interested in owning some of his own information, he was fascinated by the notion of a wearable. So we placed a CGM on him, which was able to look at the sugar content in his body of foods that he ate. And we could assess this using different devices. The particular device we used is placed on the tricep, and it looks at patterns when you eat. And each individual has quite a different pattern. And it's fascinating to people to get this information at the point of eating instead of waiting for data to come back and just getting one moment in time through a fast. And so he was able to do just this and change the patterns for himself. I want to share another study with you that actually looked at metabolic typing. This was reported in Cell and showed that you can take many individuals. I think this study was done in about 1,000 individuals. And if I point to the upper right-hand side as you're facing the slide, you'll see that this particular participant, number 445, when eating a banana, there was a rise in sugar. But when eating a cookie, as shown by the blue line, the banana is in the yellow line, quite appropriately, the banana caused the sugar to go up higher than the cookie. But if you compare that individual to the other participant, number 644, the reverse happened. The cookie caused the sugar to go up, whereas the banana did not. So you can see when you look at averages of people, you squash differences, you can't really discern what a particular individual is going to do. I've been wearing one of these monitors despite not being a diabetic for about 3 years now, and it's completely changed as an endocrinologist that I am, my understanding of my own function. And I can't urge all of us enough to understand that N-of-1 approach to figuring out how our bodies function is going to be the medicine of the future. Here you can see that leveraging N-of-1 data and patterns over time is vital. And there's a number of ways we look at it, and we do a deep dive into each of the individuals that come to the center ultimately, although much of what we do is telephonic and at a distance, and the changes that happen over time can really make a difference. His PSA here, just to pick out a couple of numbers, stayed steady despite what we were doing, which is excellent. We want that to change. A number of his variables did change over time, and we adjust accordingly. I would like to talk for a moment about how we think of the N-of-1 approach. And this, to me, goes way back a couple of decades. And it rests in the fact that N-of-1 essentially starts with observing, as we have thousands of individuals, and collecting a data designed as a clinical investigative trial. And as you do that, you're looking at data that forms patterns. Enough folks fall into certain patterned responses. And as you collect that data, you're able to observe it, look at it, and over time formulate a population theory. In contrast to collecting lots and lots of data, the way the NIH is approaching it, looking at 1 million lives, and then theorizing how to bring that down to the individual. In fact, in that paper that I started out with in Nature by Nicholas Stork in April of 2015, he described what I've been doing here at the center for over 2 decades, in New York for slightly over a decade, about 13 years now. And what Nicholas Stork actually wrote out is that this N-of-1 approach essentially starts out small and focused and then works its way towards insights that would immediately benefit a much larger group. And that's what we have found, because I want to stress that, of course, you can't study globally what we need to determine to help everybody in the way we're doing it at the center, one at a time. But we have plans to scale this kind of approach into an app that will allow us to offer this kind of approach broadly. And here you can see what we intend to do is take the patterns that we have now been studying and look at the individuals, whether green or pink or blue, collect all the essential data that we want to collect, offer it up through the app, and offer it globally, so that by seeing and quantifying this data and marrying it to the particular story of an individual, we'd be able to evoke change that would have an individual change their path so that they can own their own health destiny. I hope this makes sense. It's been fun to talk about what we've been doing here in New York. Thank you. If you feel interested in contacting us, please feel free both to send an email here, and I'm happy to answer through this presentation. If you'd like to reach us beyond this, you can feel free to write to us through the website at info@comitemd.com. Thank you very much.